Hey guys, we're gonna go over Swan basics and then Swan insertion. It's me and Jen here. We're gonna talk about like the different ports that you have on the Swan. So the blue port here, this is used mostly for medication
CVP
purposes.
medication, and you can do continuous or intermittent infusion.
Okay, and then we have the yellow. This is the PA port. This is also for monitoring line, so you don't usually give medications.
Give no medications through that, and just put a pressure line to it.
Okay, and then we have the balloon line. So this line is with a dedicated syringe that goes at the end of it that is used to inflate the end of the PA, which is right over here. Okay, and inflates. This one doesn't have it, but it should have a little balloon here on top. Okay, and then you have the white port. This is used for medications?
No.
Okay.
You'll have two ports here that would be used for an adaptation as well to do continuous SVO2 monitoring. Some Swans may also have an additional white port, which would be for continuous infusions, and that's very good for inotrops and pressor.
Okay. Should we go over the soap hookup? Yeah.
And then when we're doing bedside Swan insertion, you want to have your pressure line primed and ready to go. You can hook it up to the monitor, have a PA line ready and visible on the monitor, flushed all the way through. And then once the physician is ready and the introducer is placed, we can connect the pressure line to the PA catheter.
All right. So we'll start, I guess, with the insertion part of this one here. So initially, before you even are touching the Swan Gans catheter itself, you're going to insert either a regular cordis catheter or a MAC cordis catheter. Those are the ones that we have. Really important to know what type of French Swan works with each catheter. So these cordis catheters, I believe, fit 7 and 7.5 French Swans, which is the one that we have here. Okay, so this is what's actually going to go into the patient's neck. Basically, it kind of goes in their IJ. So it's like this. You have this port that will sit either on the outside. It's nicer if you can place it and the port stays out, so it's not kind of getting in the patient's neck anywhere. Okay, so this is going to go inside the patient's neck. You suture it. Usually I will suture it right here, and then sometimes, just to kind of help, this is the problem when these lines don't draw back. The typical reason why that doesn't work is because this is actually kinked. Okay, so sometimes what I like to do is I actually like to throw a suture in right here, and then I'll throw a suture in right here as well to kind of prevent this from kinking. So if you guys ever see, or if you're having difficulty drawing from the Swans, but I can bet you the majority of the time is because it's kinked like this and it actually doesn't have a good flow. All right. This is the catheter that's going to go around the Swan and keep it sterile. So before we ever float it into the patient through the cordis catheter, this would get advanced through the Swan. I'll show you guys how to do it. So it's important to know which way goes where, because this is going to lock right over here. Okay. So this is how this locks. All right, you see that little divot over here, then you push it in and lock it. Okay, so that's how it's going to look once we actually insert the Swan itself. And then to unlock it, you just kind of twist it over the divot and pull. Okay, so what you do is you will float this Swan all the way through. Okay, it's going to stay in this locked position. And then typically I kind of float it because I want to make sure I have as much room on the Swan to float into the patient. So imagine this is all sterile here. I would float it pretty high up and I would lock it into position probably as high up as I can go, which would be kind of around here. And then once you're here, you lock from this screen. Okay. And then this is kind of how it stays, because the rest of you are going to float. So you can see that you actually don't really have too much room on the Swan itself. This is what's going to go into the patient's body. And while we're getting this part set up, I like to actually twist the Swan around, kind of maintain its shape, because it kind of loses. This is the shape, the way that you kind of want it to go when you're floating. You want to take it, maintain this curve, because you can imagine if this is going into someone's heart. So you're inserting it through here. It goes into the right atrium, the right ventricle, and then basically kind of follows the contours of the patient's heart into the pulmonary artery. Okay, so I like to maintain that shape so that way it doesn't lose form while we're waiting to get everything else set up on the back end. And then normally what I would do once I have all this set up, I get sterile OR towels, the blue OR towels, and I will wrap all of this in blue OR towels to keep this sterile. And then beyond this point, this is usually going to be like off the patient's bed, someone else is holding this. I am keeping all of this sterile on my own, okay? All right. So now this is, we'll pretend this is like the insertion part. So what I do is say again? Test the balloon first. Oh yeah. Okay. Oh, sorry. Yeah.
So before that's inserted into the patient, and once the unsterile portion is now handed to the assistant, you can connect your pressure bag to your PA line. You want to have the pressure line already connected to the monitor so you're able to see waveforms as well too, and then flush all the way through.
Yeah, so now you're testing all the different ports for the flushing. So like the PA port, CVP port.
Okay. And then after your line is set up ready to go, you want to make sure that you have changed the screen on your monitor for Swan insertion. If you go up to the upper right-hand corner where it says dynamic wave, you can choose your screen for Swan GANS insert. That makes your PA block quite big, and you're able to see changes in your waveform so that you know where you're at within the heart. And then as you're advancing the Swan catheter through the cordis and into the heart, you'll be able to see your location up until a wedge pressure, knowing that you're in the pulmonary artery.
Okay. And should we talk about it now, about the not using the optimum scale thing?
Yeah. It is best to not adjust your scale for optimization until the Swan GANS is inserted, so that it gives you a broader base. Usually 0 to 60, I think, is what the default is, because if you have a smaller window of what's going to be visualized based on your scale, you may not be able to see high PA pressures, and your line would look like it's flat.
Mm-hmm. Mm-hmm. Correct. And it's nice on the bigger scale that you would see when you get the step up to know that you're in the pulmonary artery, and we'll show you guys those images in just a second. Okay. So before you insert the Swan, so this is where we're kind of like have tested all the lines, make sure that we have flushed all the different access sites that we can flush. I would test the balloon, okay? And so I would hold the Swan in this position. Obviously this balloon is ruptured, but you would have the nurse inflate the balloon, okay? Or
whatever's cc's, and then you should be able to see the balloon inflate right on the very end of the tip.
Yeah, and that's where you'd see it right over here. And then you can let go, and then we'd deflate it.
And then to maintain the integrity of the balloon, the best to deflate the balloon is to remove the syringe, not pull the air back out of it, and then the air can escape passively.
All right. So now we're going to get set up to actually insert the Swan. So like I said, I usually like to maintain this position. This is just kind of like tips for people who are floating it. Like I said, I want to, as much as I can, maintain the curvature and like the way that the Swan is going to go naturally into the patient's body. So I will insert the Swan by going on a curvature that's going to go towards the patient's left side, if you can imagine this is their right, okay? And then each marker is 10 centimeters. So when I say I'm at 10 centimeters here, that was 10 centimeters right there, okay? And then 20 centimeters, you can't really see it because it's in this space right here, but kind of around here is about 20 centimeters. That's when I pause and I ask the whoever's helping me to inflate the balloon, okay? So we say balloon up at this time.
If you're looking at waveforms as well too, at 20 centimeters you should be able to see a CVP waveform towards the right atrium, because that's where you're going to end up. And then we would inflate the balloon.
Okay. And then once you're here, you kind of want to do this relatively quickly while looking at the waveform, because like I said, as soon as you put this into someone's body, this catheter, the plastic, actually warms up and loses this stiffness that kind of helps you get in the right place. So I will say I'm at 20 centimeters, and then from there I will start inserting pretty quickly, okay? And then this is just what I do at every time that I am at a different 10 centimeter mark, I say it out loud, okay? So then I go pretty quickly, 30 centimeters, okay? And as I'm doing this, I'm looking at the screen, okay? All right, 40 centimeters, and then out loud I say, oh, when I see a big step up like this, so you're gonna see CVP waveform. When you see a big step up, that's when I know I'm in the RV. Just so you guys are aware, you don't want to spend too much time in the RV. You want to do this relatively quickly because you can cause, obviously, tachyarrhythmias. So as soon as I know I'm in the RV, I kind of start moving, again, even more quickly until I see a waveform where I get basically, it's called the step up, and that's when I know I'm in the PA. Okay, so you see RV, so it's very kind of big steps that you're taking, but here you have a little bit of a step up where it tells you that you're in the pulmonary artery. Okay, once I'm in the pulmonary artery, just kind of what I do is I will advance probably another 2 centimeters with the balloon up, and then I will take, I'll say balloon down, and then we'll have the balloon go down. Okay, and then I'll probably advance another couple of centimeters from there until I can see if I can wedge the patient. You don't always have to wedge the patient, especially, you know, I don't usually do this if it's, you know, someone that I just kind of need to get this done quickly, but it's nice to be able to wedge the patient and know what that value is, okay? You can do that, obviously, the best way to do that is with the balloon up, but I kind of just like to get it in that position so I know that the swan is an appropriate place. So once you have that, I'll talk to you guys about some tips and tricks in a second, but once I have that, I want to make note of where you are. Okay, so this is 60 centimeters, so maybe like 1 to 2 centimeters before that, so like 58. Okay, and then what you're going to do is take this sheath and you're going to unhook it, and this goes all the way down to maintain sterility, just like I showed you guys before. Okay, so this is going to go right in here, locked just like I told you guys. Okay, we're going to twist, and then this locks over here to lock the swan in position as well. So now this can't get pulled. Okay, this is all sterile here. All right, and then this is already inside the patient's body, and then you put obviously a tegaderm or a biopatch and a tegaderm on it. Okay, I'm going to just go over real quick and then when you want to remove the swan, you unlock it here. And then I would unlock it here too. Okay, and then that's when you can kind of start pulling it out. Okay, some quick tips and tricks. So if I'm ever not in the right position, or for whatever reason, let's say I didn't get into the RV, or I got into IVC, when I take the swan back out, sometimes I take it out fully, I remove it, and then I reflush all the different ports. And then I kind of twist it to get it back into this position again, okay? Another trick that I have employed before is like actually positioning the patient. So instead of lying flat, I'll have someone prop their left shoulder up a little bit, so that way when I'm floating the swan, it kind of wants to go into their PA catheter a little bit better. And then when I am advancing the catheter, I don't always just advance in a straight like fashion. I don't just push. What I'll do is I actually push and twist. So push, 10 centimeters, twist, push, 10 centimeters, twist a little bit. So that way, again, it kind of follows the natural anatomy of the heart and makes it easier for you to get into the PA. You don't always have to do that, but that's just something that I do if I know that I'm having difficulty, or if it's like a kind of a difficult swan placement, okay? And then, like I said, once you're done with that, you put the biopatch, tegaderm, and then always get a chest x-ray to confirm placement before you check numbers or before you use a line for whatever reason, okay? Anything else, Jen? Okay. All right. That's it. Thank you.